about that we are not getting out of business. In Egypt, we adopt the MD Anderson assessment of the response to the neoadjuvant chemotherapy. We make estimate of the tumor bed, tumor size, as well as cellularity, the presence and the percentage of the in situ component, coupled with the notion on the axillary lymph node status and the number of nodes and the biggest diameter.
Thank you.
Thank you very much for this enlightening lecture. Any questions? Okay, thank you.
So we are going to move for Professor Oliva Bagani from Switzerland. She is an international medical oncologist working at the Medical Oncology Department of the Oncology Institute at the Southern Switzerland. She will give us a presentation in operable breast cancer. Two presentations. The first is neoadjuvant chemotherapy and biologic therapy, and the second is neoadjuvant endocrine therapy. Please do.
Thank you. Once again, it's me. As I said before, I put the presentation in two parts, so now I try to focus on the neoadjuvant therapy for operable breast cancer, but as I said before, it's not easy because there are lots of overlapping in clinical studies, and so it's not really easy to dissect operable breast cancer. So which is the evolution of neoadjuvant treatment for breast cancer in the last decades? So we moved from locally advanced to early breast cancer, and the goal of chemotherapy was at the beginning increasing local control, and we were successful. Then we moved to early breast cancer to increase breast conservation, and we was successful mid-80s. Then we wanted to improve survival in early breast cancer with preoperative chemotherapy, and we were not successful in general. And we are now, as Professor Viale said, trying to use chemotherapy before surgery to improve tailoring. And we really yet don't know if we will be successful. For endocrine therapy, as I said before, the goals are different, and so one of the goals is to treat unfit elderly women, and we achieved this goal to increase breast conservation, and once again we were successful. And still open the question if with neoadjuvant endocrine therapy we can improve treatment tailoring and personalization. Which are the proven benefits of preoperative therapy in operable breast cancer? As I will show, the disease-free survival and overall survival benefit is the same as adjuvant therapy. So there is no benefit in giving chemotherapy before surgery in operable breast cancer. One of the proven benefits is the increased chance for breast-conserving therapy, and as a consequence, and maybe Maria will talk about that, to improve cosmesis. And then, and this is not a trivial issue, in some patients you have time for genetic counseling and testing, especially if they are young, and so you can impact the choice of surgical treatment. Breast cancer surgery is not an urgency. Breast cancer is not like leukemia. So most of the time, you have enough time to discuss with your team and your patients all the options, and you have time to plan for the patients the best strategy. Which are the potential benefits? So you have the opportunity, and this is a research tool, to monitor response to therapy, and so to select the best chemotherapy or the best drugs in the individual patients. But as we saw before with the GEPARD-3 trial, there is no data proving that adjustments ongoing chemotherapy improve outcomes, and the evidence is the contrary. As Maria said, and she will probably discuss this in her talk, the decreased need for axillary dissection is, of course, very exciting, but it's controversial, and it's still a matter of debate and research. But of course, and we saw it before, the residual cancer burden is strongly prognostic, at least for triple negative and HER2 positive, of long-term outcome. And then, of course, you have research benefit, as said before, to identify molecular predictors of response, to test new drugs, and to identify, and we really urgently need markers of drug effects. We don't have any reliable marker, and compare and identify very rapidly sparing loss of patients. Adjuvant treatment, you need in clinical trials thousands of patients. In neoadjuvant, you need hundreds of patients. And so this is a very huge improvement. So as I said before, the likelihood of response depends on the kind of tumor you have. And so there is a continuum. There is endocrine-dependent tumor are less likely to respond to chemotherapy and vice versa. So you have some tool to understand if your patients will respond or not to your therapy, provided you have a good pathologist. I think we really, with this, and you will thank me, Beppe, afterwards, we desperately need good pathologists because we base our decision on their response, on their report. And so we need to trust them, and we need to teach them how to give us the better information because we base our decision on their report. Once again, ER is unselected disease to start with, and several, and this is a review, recent review, in several randomized trials, at least 3 huge trials, showed that you have the same disease-free and overall survival in patients with operable breast cancer with neoadjuvant or adjuvant chemotherapy. I will just show the European trial where the 3 arms were surgery first, and then anthracyclines and the old CMF, and then the comparison or adjuvant or neoadjuvant, more modern chemotherapy, anthracycline and taxane followed by CMF, or before or after surgery, consistent number of patients. And you can see that there is no advantage in giving modern chemotherapy before or after surgery in operable disease. What about HER2 disease? This is a different issue. This is a different population, and we have a huge amount of data. And the first trial is the NOAA trial, where the comparison was between in HER2 positive and also in a subset of HER2 negative patients of trastuzumab, and it was an anthracycline taxane based plus or minus chemotherapy plus or minus trastuzumab. And in this population you had quite a consistent amount of inflammatory breast cancer as well. And the results, which are not surprising, show a huge benefit of adding trastuzumab to chemotherapy in this population. And there is no difference, of course, in HER2 negative disease between the different arms. And if you look, because we talked about inflammatory breast cancer before, in the subset of inflammatory breast cancer, the response was even better when adding trastuzumab. The Guépard-Quinto trial, we saw the Guépard-Quinto trial in HER2 negative patients before. This is the HER2 positive population. And this was a direct comparison, the same chemotherapy backbone, and a direct comparison between trastuzumab and lapatinib. The proportion of patients who were operable at randomization was huge, 82%, but this was not only in operable breast cancer, but the majority of them were operable. And you probably saw these results before. The trastuzumab is the winner. And you can see in the population of, if you measure no invasive residual disease in breast and nose, or in breast only, and there is a significant difference between trastuzumab and lapatinib. This is the famous and quite interesting from a biological point of view NEO-ALTO trial, where the inflammatory breast cancer was excluded, 455 patients. A smaller amount of patients were operable and candidate to breast conservative surgery, which is not, it's not operable, but it means that 30% of these patients had a less extended disease at enrollment, and the comparison was between lapatinib, paclitaxel, and trastuzumab and paclitaxel, so a head-to-head comparison, and the combination of the two anti-HER2 treatment plus paclitaxel, and you had a 6 weeks treatment with only anti-HER2 treatment before chemotherapy. And then they went on after surgery with chemotherapy, anthracycline-based, and the same anti-HER2 therapy. And once again, the results are published, and you can see that in this subset of patients, there is no statistically significant difference between lapatinib and trastuzumab. So the results, the preliminary results of the ALTO trial, so the adjuvant trial, which showed lapatinib to be inferior, were not predicted by the neoadjuvant component. And as you can see, the blocking with the dual HER2 drugs is much better than giving one of them alone. And this is on breast and nodes. And you can see that the difference is striking in HER2, in ER negative disease. So you can have a highly significant difference in ER negative patients as well as compared to ER positive patients. This is the Neosphere results, which compares trastuzumab and pertuzumab, and we have in this trial they had a dual inhibition as well, with the backbone of taxotere. Once again, you have here 60% of patients were operable at the beginning. So it's a different population. And what you see, which is similar to the NEO-ALTO trial, is that the combination of chemotherapy, taxotere in this case, with Herceptin and pertuzumab is much better than the chemotherapy with trastuzumab or pertuzumab alone. And you have quite a significant response, which is not trivial, 17%, when using the double targeting therapy alone without chemotherapy. And once again, as in the NEO-ALTO trial, you have a significantly different response in all groups, but especially in the three drugs combination in ER negative population. So this is the comparison of the three trials, and I would like to focus on the fact that you can have a consistent response in giving a consistent improvement in giving the combination of the dual targeting. Of course, this is important, this is intriguing, but raises the problem of cost, because giving your patients the dual inhibition is very, very expensive, and despite Roche is a Swiss company, so I would be, of course, in favor of promoting a Swiss company. I think this is not affordable, even in Switzerland, to give all our HER2 positive patients the double combination. And so we have huge amount of problems. The patent for Herceptin will expire in 2014. So I think lots of research and investment should be done in developing biosimilar, because we won't be able to afford these kinds of expenses in the near future in all countries. So other approaches are to give, this is another trial run by our Italian colleague, Dottoressa Guarneri, comparing once again a backbone of chemotherapy, anthracycline and taxane, and the combination of lapatinib and trastuzumab, and this is another trial presented at ASCO by Dr. Holmes, and this is a very, very, very courageous study with only dual combination. So this is a small trial, 56 patients, but you can see that only with anti-HER2 therapy you can achieve 40% response and 21% of pathological complete remission in breast. So this is an overview of the three studies. They are three studies of relatively small size. One is not randomized, the last I showed, but they reinforce the clinical merit of dual HER2 blockade shown in biggest trials. So some patients, and not and quite a consistent number of patients, achieve pathological complete remission without chemotherapy. Of course, we do not have disease-free survival results yet, so we have to wait, but this is a very interesting approach. So, in conclusion, in operable breast cancer, you have a similar local-regional control, disease-free survival, and overall survival as adjuvant treatment. So you really do not need to give preoperative therapy to these patients, but you can gain a higher rate of breast conservation, and so it can be offered when adjuvant chemotherapy is indicated. We need, as in the locally advanced breast cancer setting, predictors of response, and as in the locally advanced, ER, PGR absence, triple negative, grade 3, non-lobular, and young age are good predictors of response. The likelihood of long-term disease-free and overall survival varies in different molecular subtypes. There is no difference between the operable and the locally advanced setting. PCR may be an appropriate surrogate marker, especially for long-term outcome, especially in triple negative and HER2 subtypes. and no invasive residual or DCIS in breast and nodes should be used as the definition of PCR, as the current definition of PCR. Once again, I want to stress that the neoadjuvant treatment requires a multidisciplinary approach. And as Maria said, you need the surgeon on your side. At the beginning, he or she needs to see the patient up front and need to see the patient along treatment. So it's really a teamwork. Anthracycline and taxane-based regimens are the standard so far. We saw in the previous lecture that there is no advantage to shift to antimetabolites to add bevacizumab so far, and they should be given over 4 to 6 months. So you should keep, unless a patient is in clear progression, you should give the entire course of the treatment. Anti-HER2 therapy in HER2-positive disease is mandatory. You can have a very good response with taxanes and Herceptin. Currently, there is no room for anti-HER2 treatments which are different from trastuzumab outside clinical trial. And other targeted approaches like bevacizumab should be limited to clinical trials so far. Thank you.